Okay. Good afternoon, everybody, and thank you very much for joining us during this webinar focused on distal radial access. These are Gabriele Gasparini and Damiano Ragazzoli speaking from Humanitas Research Hospital in Milan. And first of all, we would like to thank the Cordis company for supporting this interesting initiative because we strongly believe in this project, and also we strongly believe in the utility of this new, quite new distal radial access. So during this webinar, we go through the different aspects, starting from the rationale to specific subset like acute coronary syndrome or even chronic total occlusion. So all of us know perfectly the history of transradial approach that was first described more than 40 years ago. And all of us know perfectly then the main advantages of radial access is the reduction in terms of bleeding and mortality. And nowadays, this radial access has become the default option for the majority of procedure in the cath lab, starting from diagnostic and also complex percutaneous intervention. But the main disadvantage of this access is the radial artery occlusion. That is the most common, most frequent complication after transradial catheterization. The incidence vary between 1 and 10% of the case, depending on the series. And this is an important complication because the radial occlusion could be a problem in case of future transradial access or in case of the need of utilization of radial artery as a conduit for coronary artery bypass graft. So this is a review, and the result in terms of radial artery occlusion at the forearm, it's range between less than 1% up to 33%. So it's the incidence is very different depending on the series, but it's a real complication. And despite this complication, transradial access is the default strategy that is strongly suggested by the community of interventional cardiologists. This is a report, an update from the American Heart Association, in which the transradial access is suggested as a default strategy in patients presenting with acute coronary syndrome because of a great reduction in terms of bleeding and vascular complication compared with the transfemoral approach. And when we have to decide between right radial or left radial, also we have some data coming from the literature, and with an appropriate learning curve and patient assessment, right and left access are equally safe and effective. And furthermore, when we use left radial approach, we can achieve more support and we can advance more easy the guiding the catheter or the guiding catheter that are designed for the transfemoral approach. So if we look this data that compare the transradial, the left transradial with the right transradial access, one of the advantage of using left radial access is due to a reduction in terms of fluoroscopy and contrast use, because it's more easy to engage the coronary ostium using the left radial access. And in terms of complication, it seems that the left radial access could reduce the rate of cerebrovascular complication, I mean stroke-related complication. So what we know about the radial artery? The radial artery, the first description, as I said before, was more than 40 years ago, and during this long period of time, the access, the radial access, improve during time, and we know that there are some other aspect that could lead the distal radial access a good and safe access for transradial approach. First of all, that the course of the vessel are more superficially and runs along hard bones. So in this case, could make easier to compress the distal radial access, reducing even more the rate of vascular complication and lead to achieve a faster hemostasis. And furthermore, puncturing the distal radial access could maintain the antegrade flow through the radial artery, even in case of occlusion, because the perfusion of the hand is supplied by the superficial palmar branch. And we will see in the next presentation this aspect of the anatomy. So when we have a general view of the radial artery, now we can consider three different access. The traditional at the forearm level, it is the traditional radial puncture in the wrist, and the two different access at the level of the scaphoid and at the level of the trapezium. This case is the traditional snuff box access, and this is the distal access, the distal radial access. So this is the new concept of distal. This is the new concept of radial access. And the first description of the distal radial access was about 10 years ago, and it was described by Babunashvili, that he performed his first case using the distal radial access to recanalize a total occlusion of the right of the radial artery at the forearm. Then all of you knows perfectly the paper from Ferdinand Quimenet and his large series through the anatomical snuff box for coronary angiography and intervention. Then, after the paper of Quimenet, the distal radial access became viral through the social. But despite the viral situation of the radial access, the distal radial access, we have to consider, obviously, what is the rationale of this new access. First of all, the main important aspect of this access is that reduce the risk of radial artery occlusion at the forearm and bleeding and vascular access size complication. This is one of the most one of the most frequent complication of radial access, and if we have the possibility to reduce the rate of radial artery occlusion at the forearm, I think that it would be very helpful and useful for our patient. Then, this radial approach that does not only prevent the occlusion at the forearm, but it also the main site for retrograde recanalization in case we found radial artery occlusion. In case, and furthermore, in case of radial artery occlusion that occurred after a traditional standard catheterization from the conventional radial access, the antegrade blood flow is preserved through the superficial palmar arch. So this is very important because it prevents ischemia of the hand, especially in the right-handed patient. And finally, the course of the distal radial artery is behind the compartment of forearm. So in this case, we can reduce also the risk of compartment syndrome that could happen in case of large hematoma or bleeding at the forearm. And another advantages of this access is the short compression time that facilitate outpatient PCI. It is a very important and very actual aspect in our daily practice in the cath lab. And then finally, last but not least, the preservation of the radial artery at the forearm for future catheterization or for need of radial artery as a conduit for coronary artery bypass graft. This is a case that we did just a few days ago, where we performed coronary angiography in a previous CABG female patient, and we We use now, since last 6 months, we are using as a default approach distal radial access in all commerce patients. So in this case, we puncture with no difficulty the distal radial access, but then we found total occlusion of the radial artery at the forearm. So in this case, we decided to perform a recanalization of the artery in order to be able to continue with our diagnostic exam. So we advanced a polymeric guide wire directly through the needle, and this was a Sion Black that was pushed in a star technique, as a star technique in a star fashion, and it was able to re-enter the true lumen distally to the elbow. In this case, we were able to advance the sheet until the elbow, and then we perform our procedure. At the end, we achieve a complete recanalization just with the sheet advancement without needing of using balloon or drug-eluting balloon. This is the final result. So it's a very useful access also in case of distal radial access, in case of radial artery occlusion. This is some pictures that explain the concept, how the position of the radial artery at the forearm is behind the origin of the superficial palmar branch. So in case of occlusion of the distal radial artery after the puncture or after the catheterization, the flow to the hand is maintained through the superficial palmar branch of the artery. It's a very interesting pictures now. So the origin of the branch that supplies superficial palmar branch are proximal to the snuff box. And even in case of distal access, this is the puncture site in the snuff box, and this is the distal site for the puncture of the distal radial access. So in this case, we can maintain the flow to the hand also in case of occlusion of the distal radial artery. And this is an example of the previous concept that I explained you. This is a case modeling of ulnar artery occlusion with the active flow through the radial artery in the artery. In this case, we can observe the palmar arch that supplies the flow to the hand, to the finger. And this is, in contrast, the case of forearm radial occlusion, and the flow is maintained through the ulnar artery that fills the palmar arch. Okay, this is the classical case that occurs during the radial occlusion, but at the forearm. But if we use the distal radial, this is what happened in case of occlusion of the distal radial artery in the snuff box, in the anatomical snuff box. We can have an active blood flow to the hand, both from the radial and ulnar arteries through the palmar arches. So this is a very impressive slide that show you the benefit of using the distal radial access in terms of preservation of vascularization of the hand. So, but what about the rate, the risk of occlusion of the distal radial? We talk about the rate of occlusion of the forearm radial artery access. We saw the picture of the meta-analysis on the radial artery occlusion at the forearm, but some data are available also regarding the rate of occlusion in the snuff box in case of distal radial access, and the occlusion are rare, and when they happen are distal. So the main the most frequent case of distal radial artery occlusion is when we puncture the distal, when we use the distal radial access. And about the rationale and the main advantages of using this access, we discussed about the anatomy and the reduction of the risk of radial occlusion, but we have to keep in mind that several other advantages are related to the patient comfort. So this kind of access improves the patient comfort during and after the procedure, because in this case, there is no need to force supination of the forearm, and also it's possible to use this access in patients with the limited arm motion. So the comfort for patient, it's another very important aspect that we have to consider when we decide our access. Then another time, short compression time and preservation of radial access for future catheterization. But if we consider, in case of distal radial access, the difference between right distal radial and left distal radial, we can consider the left distal radial as a access with the specific advantages of left radial access. So in this case, the comfort for a right-handed patient, the less tortuosity of the vessel, or in case of needing to select an angiography, to make an angiography, a selective angiography of the left internal mammary artery, or also better manipulation of catheters that if we advance it through the left arm, it's more easy to engage the coronary artery. And then if we have to achieve more support for the right coronary artery, we can achieve an improvement of the support using the left radial access. This is for the traditional advantages from left access, and the advantage related to the distal left radial approach are the same that I mentioned before, such as improved patient comfort, but also, and I am very, I am support of the left distal radial approach, because I have some problem with my shoulder. So there is an important advantage in terms of operator comfort, because there is no need to bend over the patient. And then in terms of reduction of radiation, that can be reduced, because the patient, the operators work at the level of the knee, at the patient knee level, maintaining a safe distance from the X-ray source. Oh, sorry for the delay. So we can conclude that what are the advantages and the rationale for the using left distal radial approach. Operators' advantages are in case of need of Lima opacification, or when the right radial approach is not feasible. If we use the left radial access, we have no problem related to the presence of the arteria lusoria, less tortuosity, especially at the level of the subclavian artery. It's a natural route for the femoral shaped catheters. The patient comfort, it's another important aspect, because it's more comfortable for the patient. The operators can puncture from the right side of the patient. We don't need to bend over the patient. And also in case of obese patient, we don't need to bend over the patient. And in terms of reduction of radiation, maintaining a safe distance from X-ray source and reducing scatter from patient, and escape site in case of radial artery spasm, as we can see during the next presentation. And finally, it's a good route to open radial artery occlusion at the forearm. And we have to consider that we discuss about the advantages of this access, but there are also some disadvantages. So the rate of crossover, or the rate of failure, it's quite high even for experts, especially at the beginning during the learning curve, but it maintains quite high, about 10% of cases, even for expert operators. And we should to keep in mind that if we puncture the distal radially, especially if we decided to use the distal site of puncture, there are some tortuosity related to the origin of several side branches. So we have to manipulate it to advance the wire very gently in order to avoid potential dissection. And another aspect that we have to consider is, in case of TEL patients, sometimes the catheters which are 100 centimeter long are not enough to let us to select the coronary artery ostium. In this case, there are some tips and tricks that led us to use a guiding catheter extension to perform the angiography. And then, in case there are described some cases, a few cases of some damage to the scaphoid, because in case of distal radial occlusion, we can have some problem in terms of vascularization to the scaphoid bone. So this is the first part of our presentation, focus on why distal radial access, the advantages and the disadvantages. And before going to the next presentation, we have a dedicated chat that we can use, and the aim of this webinar is to share the experience, maintaining an interaction with the attendees. So if you have some question, you can use the chat to make the question and to stimulate interaction and discussion. So if we don't have no question time, we can go with the next presentation. Please, Damiano, this is your turn.
So welcome again. Here in the second part of the presentation, we will focus on radial artery anatomy and the puncture site for distal radial access. And then again, let me remind you that we have a dedicated chat, as Gabriele said. So feel free to send us a question or observations. We will try to be as present as possible in order to reply and to explain what is missing into the presentation. So the key points of this second presentation will be, it's a little bit boring because this is the part of the anatomy, and the anatomy is always a little bit boring. But anyway, we will focus on the vascularization of the forearm and the hand, both on the palmar and dorsal side. And obviously, we will focus on the relationship of hand vascularization with ulnar and radial artery. And then we will focus on defining the skin and bone references for puncture site for distal radial access. So this image that was already shown by Gabriele, it's fundamental in our opinion, because we here can see the palmar view of the hand. We have two different arches that give supply to hand vascularization and to finger vascularization. We all know that at the level of the cubital fossa, the brachial artery branches into radial and ulnar artery. The ulnar artery lies in the medial part of the hand, and anatomically it's quite always the same, with no or minimal anatomic variation. On the other hand, the radial artery lies in the lateral part of the hand and gives origin with the ulnar artery itself to three different arches. One is on the dorsal side of the hand. It's less important because the vascularization of the dorsal arch is poor. It's not fundamental, and it plus it's made of a lot of anastomosis. But anyway, the most important part are the palmar arches that are the deep and the superficial palmar arches. And we have to know that the deep palmar arch is always 99% of cases complete. It means that the deep palmar arch, it's always from the first finger to the last finger supplied by both ulnar and radial artery. On the other end, the superficial palmar arch, it's in the 50% of cases incomplete. So it means that the first three fingers are supplied by the radial artery, and the last two or three fingers are supplied by the ulnar artery. And it's important because, as already Gabriele told us, the superficial palmar arch is provided by a proximal branch of the radial artery. And in case of occlusion, in case of proximal occlusion, so at the level of the wrist, we can have a blood flow problem into the superficial arch. So this is more or less the same slide, just to remember that one arch is almost always complete and the other on the other side is not always complete. And here is the standard puncture site, so it's easy to understand that if you make some damage here, you will lose the vascularization of the deep, but it's not a big deal because the deep is vascularized also by the ulnar artery, but more importantly of the superficial arch that is not always supplied by the ulnar artery. While if you puncture here distally, you won't have this the same problem. So this is almost the same thing. A proximal occlusion will hamper the flow on both arches, while a distal occlusion, this is a dorsal view of the hand, will hamper only the superficial, the deep palmar arch. And the second big deal about anatomy of distal radial artery is that it's way beyond the compartments of the forearm. We know that the radial artery lies in the posterior compartment, while the ulnar artery lies in the ulnar or anterior compartment. And in case of bleeding, you can have, it's rare. In fact, we see it, I think, less than once per year. But anyway, you can see it once per year. You can have a compartment syndrome, and distal radial artery access is not prone to this problem. So this was the anatomical part, but the most important part, because it's practical and is less boring, is that in fact distal radial artery is made of two different puncture sites. So we can puncture distal radial artery in this proximal, relatively proximal obviously, puncture site, that is the anatomical snuff box puncture site, and it lies between the tendon of extensor pollicis longus and brevis, so these two tendons. And or if we prefer, we can puncture the distal or very distal or distal dorsal radial artery way beyond the extensor pollicis longus. So this is a scheme where you can find the same thing, the two tendons, and here you have the anatomical snuff box, and here the distal. But obviously, how to translate, the question is how to translate this scheme on your skin. It's not difficult, because this is something that we do, and that we did at the first time, at the first phase of our learning curve. We draw where we felt the pulse. Obviously, here we felt the pulse of the conventional radial artery. Here, no pulse. Here, again, radial pulse. Here, no pulse. And in this distal part, then again, pulse. And what it means? Obviously, the part without pulse are the extensor pollicis brevis and the extensor pollicis longus. So the pulseless part of the artery are where the tendons lies. So, in fact, our puncture site may be this one, anatomical snuff box, or this one, dorsal distal or distal radial artery. And it's quite easy because our references are quite clear, and the pulse is really a nice guide for us. On the other end, we can also search references on our bones, and we have to remember that, as already Gabriele told us, anatomical snuff box is just over the scaphoid bone, and it's a good thing because the scaphoid bone is really near the artery and really hard and quite easy to compress on, while the distal puncture site it's located over the trapezium bone or the first metacarpal bone, and it's less easy to compress because they are bones that are prone to movement, so they are less easy to compress on. So this is the distal, the typical distal puncture. So the snuff box site is easier to see when you extend the thumb, the first finger, but it's easier to puncture if you flex your thumb, your first finger, so you can puncture just above the pulse, because the pulse is really a good landmark. It's a good puncture site because it's easy to palpate, really easy to palpate. At the beginning, it felt strange for us to search this spot, but now it's the first thing that we do when a patient comes in the cath lab. It's no more to palpate here, but it's to search the pulse here because it's easier for us to puncture there, and it's more proximal and avoid some recurrent vessels like dorsal carpal arch, or even the superficial radial artery, the superficial palmar arch, and it's easier to compress because the scaphoid bone is really hard and is easy to compress on. And this is our puncture site. The really good thing about anatomical snuff box puncture site is that you puncture the artery not in a prone position, not in a supine position, but in a lateral position that it's really comfortable for patients and operators if you go to the left radial. While the second puncture spot is the dorsal distal, the really distal artery, radial artery. It's just beyond the extensor longus of longus pollicis, and it's a little bit deeper, so it takes a little bit of time to find the artery when you are searching for the pulse, and it's a little bit less easy to compress because the scaphoid bone is not the trapezoid bone is not easy to compress on like the scaphoid bone, and you can have some local hematoma, and we will see some example later.
Just from yesterday.
Yes, just from yesterday, because every day we perform between 3 and 6 distal radial artery punctures, so our experience is growing day by day. On the other hand, the distal radial artery puncture site is performed in a lateral prone position. So you have to put your hand like this, the patient hand like this. So it's not lateral, but it's 60 degrees. Here we have the same thing, but on real life anatomy. In this case, it was one of our first patients
2 years ago.
2 years ago, Gabriele.
Yeah.
Here punctured the distal puncture site, and you can see here the dorsal arch and also the superficial palmar arch, and in here it was the snuff box puncture site. So in the first few patients, we tried to go distal. Now we moved in a first snuff box position. And as already Gabriele showed us, is a good puncture point, is a good access point also for radial artery occlusion recanalization. That is something that we are starting now doing routinely if needed, obviously. So this was the part about the anatomy. So we know that it's a little bit boring, but anyway, anatomy is always like that, and it's easy. You have to believe us. It's easier when you do it a lot, because you are always searching for some landmark, for some point to find where you have to stick your needle, and you have to search your perfect puncture point. But anyway, the first and the most important thing is to find the pulse. So if you find the pulse, the puncture will be easy and without any big anatomical problem. So you have to believe us that when you did some time, usually it's not so difficult to find out your route.
Yeah, I would like to add also to underline another consideration. I think, in my opinion, that the main advantages for me, but for the majority of the operator, is the operator comfort. I mean, when we have to perform a left radial access, the problem of bending over the patient, it's really a problem because of pain, back pain. And so I suffer from back pain a lot. I think that this is a problem of all of interventional cardiologists during time. So the comfort of the operator is the main advantages of this access, because there is no need to bend over the patient. You can work at the knee level without any problem for your back. So this is just to underline this advantage. And if we don't have any other comments from the chat or question, we can go through the next presentation that is focused on the puncture technique. We evaluate with Damiano in his great presentation the anatomical access and the anatomical aspect to identify the radial artery. And now we consider the puncture technique. So first of all, as in case of radial artery at the forearm evaluation, we have to find the pulse. So the site of the strongest distal radial artery pulse is detected by manual palpation, as in case of traditional conventional transradial access. To facilitate to find the pulse, patient is asked to grasp his thumb under the other forefinger. In this case, it's easier to find the pulse in the anatomical snuff box. So this is the patient that we saw the image just a few slides ago, and then in this case, it could be useful at the beginning of your learning curve to draw on the skin of the patient the vessel course in order to identify where to perform the xylocaine and when you perform your puncture. Could be very, very useful at the beginning, because sometimes when the patient is prepared on the table, it's not so easy to find the same pulse that you find 5 minutes before. So this is the patient preparation in case of left distal radial access. So in this case, the left upper arm is placed on the left side of the patient on a cushion, and then the left hand is bent over the right groin of the patient. Then the patient is asked to grasp his thumb, and then we find the strongest pulse of the radial artery by manual palpation. This is for the left distal radial access, and for the radial distal radial access, the patient preparation is very similar to the traditional preparation that we use in case of standard right radial access at the forearm. So the puncture technique, all of you knows that there are two different strategies in order to puncture the artery, and one of technique use an open needle, and then using over the needle, the needle with the cannula. But in case of distal radial access, is strongly encouraged to use the open needle, because using over the needle with a cannula could be painful for the patient, because a true puncture is not really recommended in this case, in this approach, since the needle will touch the periosteum and could be very painful for the patient. So the technique that are suggested is to use the open needle technique. And the artery is punctured with the 21 gauge needle under an angle of 30-45 degree, and most important to keep in mind, from lateral to medial, because this is the course of the vessel. And when you have to puncture, we have to remember that we have to puncture from lateral to medial. And the needle is directed to the point of strongest pulse and proximal in the anatomical snuff box. This is another example of the direction of the needle. This is a right distal radial approach, and the direction of the needle is from lateral in the anatomical snuff box. I mean, we have to direct the needle from lateral to medial, following the course of the vessel. Some operators used to follow with his or her finger the course of the vessel, even at the forearm, just to have a better idea of the vessel course, to direct the needle in the proper direction. It depends of your learning curve, or it depends of your personal discretion. Now we are going to show you three different techniques, three different puncture performed from three different operators in our cath lab. And you can see how, when you direct the needle from lateral to medial, how it's easy at the second time performing just one puncture. You have to redirect the needle very carefully in order to avoid any damage of the artery of the nerve. This is the first case performed from Damiano, if I remember well. And this is a puncture that I performed. So look, from lateral to medial, and the pulse, it's very good. If you feel some resistance advancing the Y, you have to wait. You can check with the contrast directly through the needle, but you don't have to push the Y. You have to avoid any strong. And this is the third operator, from lateral to medial, with the finger on the point of the strongest pulse, and very, very backflow, very, very good backflow through the needle. So these were three different videos performed from two different operators, showing you the correct technique without using of ultrasound, but just to just perform it using manual palpation. I mean, this is in our during our learning curve, we use ultrasound to evaluate the best technique to puncture. But when you become confident with this technique, it's not really mandatory to use the ultrasound. But we should keep in mind that at the beginning, or in case of difficulty to identify or to puncture the distal radial, we can use the ultrasound to identify the distal radial artery, in order also to identify the flow or the diameter of the distal radial. But we don't forget to check the needle for confirmation of the intraluminal position, because sometimes the needle could go subintimal, and with the ultrasound it's not so easy to identify a subintimal progression of the needle. So once you check with the ultrasound the correct puncture of the vessel with the needle, you have also to check the needle to check the backflow in order to be sure of the intraluminal position of the needle.
Gabriele,
yes.
We received a question since we showed 3 different cases. The question is about which introducer sheet wire we use, spring coil or hydrophilic. What is your suggestion?
Yeah, okay. It depends on the kit that you order in your CAT lab. Now we are using, as you see in the different video, the 2 of the 3 videos, we use a spring coil wire, and in the last video, the operator was using a hydrophilic wire. So it depends of your preference, but at the beginning, I think that it's better to use a spring coil because it's safer, and you can become confident with this technique, starting from the safer wire. And then in case of some difficulties in terms of advancement of the wire, you can check with the contrast through the needle, or you can change the wire using a coronary guide wire, so at 0.14 guide wires. And this is our opinion and our suggestions, starting from a spring coil wire, and then when you become confident, you can change the wire using even a hydrophilic wire or changing with a coronary guide wires. I show you just a few minutes ago a case of advancement of a Sion black guide wire, in that case of radial occlusion at the forearm. So if you become confident, you can advance to the needle, also a polymeric guide wire, but you have to know what you want to do. So because just this example could be interesting regarding this kind of question, because if you perform a correct puncture in the anatomical snap box, maybe you don't have problems of tortuosity of collateral branches in advancing your wire, like in this case. But if you decided, or you puncture the distal radial in the dorsal part of the artery, you can have this problem that the wire goes into the dorsal the dorsal branch. So in this case, this is not really a failure, but the wires went in a side branch, in this case the dorsal branch. So you have to check with the X-ray, and then you have to withdraw the wire and redirect the wire through the snap box and then through the forearm. So this is an example of a correct progression of the wire. If you did a correct puncture into the anatomical snap box, you don't find any tortuosity of your wire when you advance the wire. But in case of distal access, so we are dorsal access, in this case, as you can see here, you have some tortuosity in the anatomy, because the radial artery course is in the anatomical snap box and then at the forearm. So in this case, you can have several tortuosities. So it's better to advance a spring coil, and in case of difficulty, you should never push the wire. You can change with a safer wire or with a coronary dedicated guide wire in order to advance the wire through the forearm. And then this is the branch, this is the dorsal branch. So sometimes, like in this case, you puncture correctly the distal. This is a distal puncture. This is a correct puncture of distal radial, but it's not a failure because the wire went into the dorsal branch. So you have to withdraw the wire and then to try to redirect the wire to achieve the radial artery more proximally in this case. Okay. So once we puncture the artery with the needle and once we advance the wire, we have to advance the sheet. So depending on the procedure that we are going to do, we can select 4, 5, 6 French, and then at the end of this webinar, we will show you also that it's possible to advance a 7 French guiding catheter to 7 French sheet through the distal radial artery. Importantly, before advancing the sheath, you have to, we suggest to perform a small skin incision, because in this case, this strategy prevents damage to the tip of the introducer and the sheath, and finally we reduce the damage of the artery. So this is a good strategy to keep in mind before advancing the sheath. And what about the diameter? Because this is a very important parameter that we have to consider when we decide which size of sheath to advance. There are some data from the literature that show that the distal radial artery diameter in the snuff box, it's more or less 0.5 millimeter less than radial artery diameter at the forearm. So we have to consider a diameter about 2.6 millimeter. This is very important because we should know the diameter, the outer diameter of the sheath that we have to advance. And fortunately, the new technologies has helped us reducing the profile of the outer diameter of the sheath. I mean, the new sheath that are available from Cordis, are called RAIN, are very useful because if we consider, the diameter, the outer diameter of the introducer, the new RAIN sheath introducer, if we advance a 6 French, we have 2.47 millimeters in terms of outer diameter. That it's perfect. It's compatible with the mean diameter that was found in this study about the diameter of the distal radial access. So we can advance in a very safe way 6 French RAIN sheath introducer through the distal radial access. This is an angio that was taken using a 6 French guiding catheter that the diameter was about, this is RAIN sheath, not a guiding catheter, 6 French RAIN sheath introducer. And you can appreciate that the diameter of the vessel is very close to the diameter of the sheath. This is very important to avoid one of the most frequent cases of transradial failure, that is due to radial spasm. You know perfectly in your daily practice that the most frequent problem that we can have using the radial access is the radial spasm. But how can we solve, or how can we overcome this problem? Obviously, we have to prevent the radial spasm, so we have to, the best way is to perform a single stick or to use a spasmolytic cocktail, but obviously you have to puncture the artery before, and then you can administer a spasmolytic cocktail. But in terms of introducer, the use of ultra low profile design sheath or with a hydrophilic coating could prevent a lot the rate of radial spasm, and that is the main cause of distal radial failure or need to perform a crossover. Another opportunity to prevent the radial spasm is to use the distal radial access, because the puncture is distal in this case, and if you advance very gently the Y, you don't have any problem with the radial spasm. So the large bore sheath play an important role in terms of radial spasm. So if we work on reduction of the outer diameter, we can solve or we can reduce the problem of radial spasm. For this reason, the technologies from rain sheet help us because of reduction of the profile is a sort of 6 in 5 concept of other companies. I mean, like Glide Sheet Slender from Terumo. The concept is quite similar. We can achieve a larger inner diameter, maintaining a lower outer diameter of our sheet, reducing the wall thickness. So in this case, this new sheet could prevent radial spasm. It could be very useful for all transradial access, but also in case of we decided to use the distal radial access because of reduction of the diameter, obviously, of the distal radially that reduced distally. And another very important and useful in case of distal radial access is this sheet are less prone to the kinking. So it's another important aspect to keep in mind, because when we have some tortuosity at the level of the distal radial access, or even in case of anatomical snapback puncture, sometimes when we move when we advance the wire, the angiographic wire, or the guiding catheter, during this maneuver, we can have a kinking. And in this case, is this introducer, this sheet is less prone to the kinking, and it's a very important aspect to consider during the distal radial, but also for all transradial access. This is the concept of 7 in 5 or 6 in 5. The concept is that I have the same inner diameter of a 6 French, reducing the outer diameter. So the outer diameter of a 6 French, it's like the outer diameter of 5 French. So for this reason, the concept is 6 in 5, the diameter of a 6 French sheet in maintaining an outer diameter of a 5 French sheet. To help you to understand this concept, we have to consider that the guiding catheters are sized by their outer diameter. I mean, the 7 French guiding catheter is sized by the outer diameter, but the sheet sized by inner diameter. So this is a 6 French sheet, but the outer diameter, in case of traditional sheet, it's 8 French. In case of 6 in 5, like Rain or like Glide Sheet Slender, 7 in 5. Okay. Next, this is the same concept. This is the concept of the Glide Slender sheet, but it's the same. So the thickness, the wall thickness is reduced, and this reduction could be the cause of the kinking. So for this reason, the technologies that prevent kinking is very, very important. And finally,
there is a question about this, and just to be more precise on this aspect. In fact, this ultra low profile introducer sheet, both the Glide Slender and the Rain, are really, really good products, and they allow us to perform complex procedures through small accesses. But what do you think that is the most important characteristic distinguishing Rain and Glide Sheet Slender from Terumo, that are both really nice products?
So the question is, what the main difference between this? Okay, I think I have the opportunity, we had the opportunity to use both of these products, and both of them are very performant. I think that one of the difference could be that the Rain sheet are, as I said, less prone to the kinking, and then compared to the Glide Sheet Slender. And then another difference is that in this case, it's the proximal part very close to the hemostatic valve of the sheet. It's not the coating, it's not hydrophilic. I mean, just a few millimeters, I think, if I remember well, 5 millimeters are not hydrophilic. This prevents the inadvertent withdrawal of the sheet when you remove the guiding catheter. So it's more stable. It's more stable once you advance in the artery. For this reason, it's more stable compared to the glide sheet slender. But I think that both of them are very useful sheet because of as you said, let us to perform complex PCI using large bore guiding catheter, 7 French guiding catheter, maintaining a reduction of the outer diameter and of the sheet, and facilitating complex PCI through radial access. So I think that then the products are very, very similar. The concept is quite similar, and it depending on the availability in your cath lab. And then another important aspect is also the transition zone from the sheet to the introducer or the dilator, because this part prevents the damage of the on the radial artery. For this reason, it's very important to perform a skin incision in order to avoid some deformation of the sheet or in the dilator when we advance the sheet through the over the wire, and leading the advancement of the sheet smoothly. So this is the importance of the hydrophilic coating for lubricity. Obviously, we need a hydrophilic coating to advance the sheet, but also this part without hydrophilic coating, it's very important to prevent the withdrawal of the sheet. This is the concept of the kinking. This is what happened with the kinking. If we experience a kink of the introducer, that could happen. The rebounded shape, it's very, very good for the range sheet. So this is one of the most advantage of this kind of sheet. And so the pharmacology is recommended, like in case of all of transradial access, we should perform heparin to prevent occlusion of the radial artery. And then depending on the operator's discretion, we can perform systematically additional vasodilators. But it depends on the situation. If you experience a radial spasm, it's mandatory, or sometimes to prevent, but it's optional. It's up to the operator discretion. And finally, last few slides are focus on the angiographic wire, because we have to consider also this aspect when we use the transradial approach, and especially in case of distal radial, because this is a case of left distal radial. If you advance the angiographic guide wire using with the flexed elbow, you can have some problem due to the loop at the level of the elbow. So first of all, we have to consider that if we encounter some resistance, we don't have to push the wire. We have to check if we are with the contrast, if we have some doubt, or better, in case of left distal radial, to ask the patient to deflect the elbow temporarily in order to allow the gear to be advanced. This is a picture, but I have also a video. No, I think that it's a picture, sorry. This was taken during our first experience in CTO PCI from distal radial. This is what happened at the level of the elbow during the elbow flexion of the elbow. You can find some resistance in terms of advancement of the wire, the angiographic wire, such as the coronary wire, depending on the wire that you choose to be advanced. But if you ask the patient to deflect the elbow of this, what happened? You don't have this loop anymore, and you can advance the angiographic guide wire without any problem. So sorry. Okay. So this is what can happen during tortuosity if you have some loop, but also in case of a side branch, if you use a traditional spring wire or polymeric wire in terms of angiographic 0.035 inch, the angiographic wire could enter into the side branch, leading some problem or difficulties to advance the wire. So now are available. There are some other guide wires that are that have high torque control and steerable wires that are less prone to enter into the side branch, and that could be very useful, in our opinion, in case of difficulty of transradial advancement of the wire. Oh, I'm sorry, but the codec is not working now. Okay, so this is, I think that these are the best guide wires that we can use in case of transradial access when you encounter some tortuosity or difficulties to be advanced. The Stork from the Cordis and also the Silverway from the Azide, they are not really different. Okay, this wire has a composite core technology that comes from Azide, but the concept is that are very steerable wires, so you can advance the wire without any problems, also in case of tortuosity or in case of friction. Both of these wires are very safe and very useful in case of tortuosity. So we have a great experience with this wire, mainly with the Cordis Stork wire, that is our default angiographic guide wire in case of tortuosity. Okay, we have a spring wire, we have the Emerald angiographic wire, the Cordis from the Stork wire, and also the polymeric angiographic guide wire, I mean from Terumo. And now it's available, the new wire, the Silverway, that its performance is very similar to the Stork one. So we suggest to use the steerable angiographic guide wire in case of difficulty in terms of advancement of angiographic guide wire.
So before moving to hemostasis, just a little bit, one question is the length of the introducer sheet that we prefer. In fact, I will tell you that me and Gabriele work with two different lengths of introducer sheet. Gabriele prefers the short one, the 10 or 11 centimeter sheet, depends on Cordis or Terumo, and I prefer to work with a long sheet. No problem using both the sheets in distal radial access. There is no major problem, no major concern. Probably the short one is easier to introduce, but then you have to face a little bit of tortuosity here. The long one, obviously, you have to advance a long introducer over a sheety, we have to tell it, a sheety wire. So the balance between one of the other must be yours, but anyway, we use both.
Yeah, I agree with your consideration, and to be honest, I change my practice with the distal radial access, because nowadays from distal radial access I prefer to use the longer one because it's more stable. Yeah, during the conventional transradial access, I was used to advance a short sheet because it was my preference. I didn't have problem with radial spasm, because the problem is that the longer one could prevent the radial spasm. But using the distal radial access nowadays, I prefer to advance the longer one because it's more stable.
Okay, let's move to this next presentation, that is hemostasis. So in fact, the introduction is quite easy. All of us consider hemostasis like the easiest part of the procedure, and we often leave it to our interventional fellows or even to cath lab nurses. But is it real? Is it really the easiest part? We have to consider that as already Gabriele showed us, the rate of occlusion of a radial artery is not negligible. And in fact, we know that the strongest predictors of radial artery occlusion are two. The first one is inadequate heparinization, so when you give less than 5,000 units of heparin. And the second one that is really important is non-patent, so occlusive hemostasis. So when you do occlusive hemostasis, you can risk to produce some kind of radial artery occlusion. So in fact, in our opinion, hemostasis is quite important, especially for this access. We can do hemostasis for distal radial artery access in three different fashions. The first one is manual compression, the second one is cheap, and it's made of bandages, and the third one, that is the one that we are using here in Humanitas, by dedicated hemostatic devices. So manual compression, we leave it only for 4 or 5 French introducer sheet in procedure with low heparinization, like a diagnostic procedure for cardiac surgery or anything else. And it's really safe because you can monitor the patency of the hemostasis by leaving a little bit the pulse, and you will have a good patent hemostasis. But on the other end, it's time consuming. So we don't like it a lot because of the cath lab workflow that is already a mess in our hospital. The second option is bandages. It's really popular in Japan, and you can do it with a pad and a tape, a pad and an elastic tape. See? And this is what we do when we don't use the dedicated devices. We use a band ball and an elastic tape. It's easy and cheap. You can do it with a distal compression and a proximal TR band. In this case, surely you will achieve a good hemostatic achievement. But anyway, you lose your advantage of distal radial artery puncture. Or you can use, and is what we are doing right now in our hospital in Humanitas, a dedicated device. They are easy to use, reliable, and really reproducible. So when you have a protocol, you can share the protocol with your nurses, and they can do it by themselves without your help, and always doing a fine-tuning of patent hemostasis without the risk of occlusive hemostasis. Usually we inflate 10 to 15 cc's of air, and we deflate it gradually in the following 2 to 4 hours. Usually the patient, because right now we are doing 60% of our PCIs and also diagnostic procedures in same-day discharge. So to achieve a same-day discharge, you have to completely remove the dedicated device before 4 to 5 hours after the procedure. So there are 2 available devices. The first one is a modified TR band. So in fact, you can use the TR band, and you have to remove this rigid plastic part from the TR band, and then you can apply it to a snuff box puncture site. Then you inflate it, and then you manage the TR band just like any other artery puncture. The other device, we are using quite a lot this Prelude Sync from Merit, and it's available for left and right puncture site. And the very good thing of this device is that it can adapt to snuff box puncture site or even to distal puncture site, while TR band, even if modified, it's not really suitable for distal puncture site because we had some failure. So in fact, we prefer to avoid the use of the modified TR band for distal puncture site. How to monitor patent hemostasis? At the beginning, it was a nightmare because it was not a standard for us to check every patient for the presence of pulse. Right now, we do it routinely. It's our method, but it's the most common one. It's called reverse Barbeau. So in fact, you have, and I will show you some videos so we don't lose time in this scheme. This is...
veramente bene, signor Marco.
Sorry.
Le coronarie erano belle strette.
So this was my voice. I was telling the patient. I was telling the patient that I had to put a lot of stents inside of his arteries. And here, this is the nurse. It's our nurse Mattia. He's inflating the modified TR band and removing the long 6-strand introducer sheet. I'll show you once again. So here, you put the TR band on. In this case, we started inflating 15, more or less 15 cc's of air. As you can see here, 15 cc's of air, inflation, and then withdrawal of the introducer sheet. Okay, and then let's move to check the patent hemostasis. Sorry, one again. Opla. So here, with the TR band inflated, and the pulse oximeter over the second finger, so in the radial part of the hand, you can see that there is a pulse on the pulse oximetry here. So in fact, it means that the ulnar circulation is good and is doing its job right now.
Okay, I have a question.
Oh.
Okay, I have a question from the chat that is related to this topic. What is the rate of patent hemostasis that you achieve in distal radial access?
So in fact, we check it. It's difficult to say because right now we always check patent hemostasis, and it's almost also in our experience is almost 100%. We did. I think Gabriele 1 billion, and in my experience 1,000 procedures without checking the patent hemostasis when we did the standard radial approach. So it's a complete change in our mind, because now we always check, and I think we always obtain a good patent hemostasis. Until 2 years ago, one year and a half ago, we never checked, and we can never tell what was for a conventional radial artery. But right now, it's easy to obtain a good patent hemostasis.
Yeah, and then there is no standard protocol that was described from distal radial patent hemostasis. We are going to participate in disco radial trial that was designed to compare the distal radial access with the conventional radial access of the forearm in order to evaluate the reduction in terms of radial occlusion of the forearm. But in the protocol, there is no any indication about the protocol to achieve the patent hemostasis in the distal radial, despite it's described a protocol to use in case of a conventional radial approach to achieve a patent hemostasis. So there are not enough data nowadays to evaluate the better way, the best strategy in terms of time or in terms of removing of the dedicated device. So we are evaluating the best strategy to adopt, and we have become confident with the reverse barbell that it's very useful in this case to evaluate to be sure of achieving a patent hemostasis.
So in fact, there is Andrea Pacchioni, one of our great friends, that tells us that patent hemostasis in case of conventional radial access is in a different series reported to be around 70%. So it's a good thing that for distal radial access, it's more than 70%. It must be, or it theoretically is always 100% patent, because you don't compress both arches, but you compress only one of them. If you puncture, obviously, the snuff box or distal radial access. But anyway, in fact, now we tend to check every time. So after the inflation of the tear band, you compress the ulnar artery. And you can see here that when the ulnar artery is compressed, the pulse is going away. And then what we do is to deflate a little bit the tear band, in this case the modified tear band, until the pulse come back. I don't know if it's something that it's related to an indirect compression of proximal arch. I don't know, but anyway, it's always good to check. We don't have always to deflate a little bit the tear band, but anyway, it's good to have a good method to check patent hemostasis. So after the hemostasis is achieved, the patient is sent to the ward where the tear band or the Merit device is progressively deflated by our nurses. And the last thing that we have to do before discharging the patient is to evaluate the access. And we always check. It's not true. We don't always check the access, but we have an internal protocol where the nurses in the ward check the access for us, and we are called every time that there is some type of hematoma. In fact, without hematoma and with pulse, the nurses do not call us before discharge. This is the easy classification of hematoma. We have to remember that by definition, for distal radial access, we cannot have type 3 or 4 or 5, so we cannot have big hematomas and compartmental syndrome. But anyway, we can sometimes have local hematoma. This is an easy one, local hematoma. In this case, the patient was admitted in the morning, did the procedure in the late morning, but he was not discharged in the afternoon because we preferred to check the evolution of the hematoma the day after, and he was discharged the morning after the procedure. So it's something that now is becoming strange for us, but anyway, in this case, we prefer to check. In this case, the pulse was present and the hematoma was really, and yes, in this case, the puncture site was the distal, not the snuff box, but the dorsal distal artery. And in this case, I have to admit that the modified tear band is not sufficient. It's not always sufficient. And the last thing is that this is not a thing that we are doing routinely right now, but we will improve our Doppler monitoring after distal and conventional radial access. You can check the artery with a small Doppler, or better with a complete echo, and it can give you obviously the patency rate and the eventual complications that are quite infrequent.
Yeah, we have an interesting question that is from our friends Andrea Pucchioni, that is another expert operator that is a fan of this radial access, and we had the opportunity to discuss one of complications that he experienced several months ago regarding index finger ischemia that occurred after distal radial access. If I remember well, we didn't have any problems in terms of finger ischemia in our experience, but the main problem that we had, especially at the beginning, was related to the hematoma.
Yes.
Yeah,
hematoma.
because we decided to become confident with both of different access, the access in the anatomical snap box and in the distal radial, and then as suggested from the mentor of this access, Ferdinand Quimenet, it's preferable to use the snuff box access because it's easier to compress, reducing the risk of hematoma. as you explained in your previous presentation. But do you remember that we had any problem of finger ischemia or not?
No, never finger ischemia. The worst complication that we had was a huge hand hematoma that we had to compress for a couple of hours, more or less. And it was localized, surely, over the wrist, so not including the forearm in the hematoma itself, but it was a huge hematoma of the hand without any neurological impact, because the patient was moving and feeling every sensation also for the radial aspect of the end. But anyway, the hematoma was huge. We had to keep the patient for an additional 24 hours to monitor the situation. Anyway, he went home fine with a good pulse. But anyway, it was our worst distal radial artery complication.
Yeah, also in that case, was related to a dorsal puncture. Also in this case. So the hematoma that we observed were more frequently related to the dorsal axis of the distal radial. So maybe if you become confident with this access, it's better to use the access the level of the anatomical snap box, because you can compress the artery over the bone.
So there is a question about the withdrawal of oral anticoagulants during invasive procedures. Right now, we still prefer to withdraw direct anticoagulation or warfarin the day before the procedure, because our rate of complex PCI is quite high, and we don't want to risk to perform a CTO or to perform a rotablator or PCI of the left main with a complete anticoagulation. But anyway, for a diagnostic procedure or for standard control that we perform less and less, but obviously sometimes we control our work on the left main, we don't withdraw anticoagulation. In fact, our experience is quite low for distal radial access and anticoagulation, but our feeling is that the advantages of conventional radial artery access are the same for distal radial access. So in fact, you can do it quite safely for the access with anticoagulation. The big deal is the heart, because obviously you don't want to perform rotablator or CTO with some risk of complication with anticoagulation, but not for the access. Access is fine.
Now, just a comment regarding the last slide, this slide, evaluating outcomes. At the beginning of our experience, and especially in that period, we decided to collect some data, and we collect also several CTO procedure performed using a 7th French that we are going to show you. But our suggestion is, as in any case of new experience or becoming confident with a new technique, we decided at the beginning to evaluate also the outcome using the ultrasound evaluation to evaluate safety in terms of a distal radial occlusion. And we perform ultrasound follow-up after 1 month from the procedure. Now, this is not really our habits, our standard practice to check the patency of the distal radial after 1 month, but we are evaluating a completely different strategy now to assess the patency of the radial artery in the forearm after 1 month. And if we find a radial artery occlusion, we scheduled a procedure for the patient to reopen the radial artery occlusion using distal radial access. So we changed completely the point of view, and now we are performing the ultrasound evaluation for the radial access, not for the radial access of the forearm, and not for the distal, in order to offer to our patient also the opportunity to reopen the radial artery at forearm in case of occlusion.
So, in fact, our presentation about distal radial access is over, but we selected a couple of subsets of patients where this access may play a major role in the next few years. In fact, we believe that when you move from an access to another, when we moved from femoral to radial access, you have to be able to perform every procedure that you are used to do in the new access. So we selected for you a couple of subsets that we tried to use here in Humanitas to push a little bit the indication for distal radial access. And the first one is the acute setting. So, in fact, we already have a good access for acute setting that is a conventional radial artery, but why not to move to distal radial artery? So, in fact, there are a couple of good advantages of distal during acute settings. The first one may be the one that already our audience outlined, is that probably, we are not sure yet, but it's possible that distal radial may have less bleeding complication than standard radial, that surely has a lot less of bleeding complication as compared with femoral. So this may be a good thing, especially in acute setting. The second one, obviously, is to have a possibility to reassess the same radial artery for eventually complete revascularization in hospital or after discharge. And we don't have to forget that 20% of our acute patients has CTOs, 20 to 30. So why not have another access for CTOs in the future? Obviously, the comfort is not negligible, especially for left radial. And obviously there are all these all the other advantages that already Gabriele showed us. There is already a publication on the topic, and Kim published this paper in the Korean Journal of Cardiology, and it was a single center registry from a center with a high volume of primary PCIs. They used 5 or 6 French sheets and a 6.5 French sheetless guiding catheter from Cortis for interventional procedures. And as standard strategies, they use bandages and not a dedicated device. Just a couple of things to underline. Is really a modern study with almost 100% of their patients that were treated with ticagrelor or prasugrel, and even 31% of patients treated still with glycoprotein inhibition. In fact, the success of distal radial access was 92%, but if you analyze the data, 5 out of 10 patients without a successful access switched to contralateral or to femoral approach. So it means that it was not a problem of distal radial artery, but probably in the proximal part of the artery, because they switched to another side or to even another access. The puncture time was quite low, usually after less than 3 minutes, and we have to outline that only 3% of the door to balloon time was related to puncture of the distal artery. Procedural time was short, but it's quite usual for acute patients. And as you can see here, puncture site complication were rare and mainly hematoma. And it's important to underline that bleeding complication were really low. Here I put the matrix just as a reference, and you can see that as compared to the matrix, the risk of bleeding complication is more or less the same, even a little bit lower, but we don't know because it's not a randomized controlled trial, but only a registry. and surely is lower than femoral access. So not a big difference between distal and standard. We tried to replicate this experience. So in November, we started our protocol, our internal protocol for a STEMI patient with distal radial access. And we tried to look for access time, patency rate, and pain. We were unlucky because after 22 patients were enrolled, COVID-19 pandemic stopped our enrollment, so we are now in standby with this protocol. In fact, among the patients that we enrolled, 16 patients received distal radial access, 1 left and 15 right. Just to show that, in fact, if you prefer right, you can do right, but it's not a problem. You can do right distal without any change. 3 patients received a standard radial approach because the operator preferred to do it so, and we did not choose to force operators to do distal. You can in this protocol you could choose whatever you want, and the 3 patients had a conversion. 1 patient with non-palpable distal, 1 patient in which the wire went in dorsal arch, and not to lose time, I preferred to switch to conventional radial artery, and 1 patient with an occluded proximal radial artery, and we had to go through a femoral access because the patient was did not have both proximal radial arteries. These were our primary endpoints. Mean puncture time was more or less 2 minutes, and we compared to our standard historically cohort that was more or less 2 minutes. Patency rate was 100%, and hemostasis was almost always performed with a TR band. Only in few cases we used the MERIT device. Pain was not a big deal. Almost all patients suffered mild to moderate pain, so not a big deal. Mean procedural time was 50 minutes, and I put here a couple of references just to show that we decided to move from femoral to radial without any advantage of complexity, just to decrease the risk of bleeding. And probably now we are ready to move from radial or femoral to distal radial without any advantages in complexity. Obviously, the puncture is difficult, as is difficult the radial puncture, as is difficult the femoral. But we can use it before of its advantages and low bleeding rates. And just to show you, this was one of the enrolled patients. The patient was symptomatic for chest pain and with an acute ST elevation in the lateral wall. And here we chose to do the whole procedure without changing any access and without changing any guiding catheter, because we really believe that whatever you can do it by transradial approach, you can do it also by distal transradial approach. In fact, here we used a 6 French short sheet, a 6 French guiding catheter, and we did a complex procedure on the left main with DCB on the ramus, drug-eluting stent on the circ, left main towards circ, pot. Obviously, the left main towards LAD suffered a little bit. We rewired the LAD and performed a reverse culotte, final kissing, final pot, and this was the final result. Is not a super complex procedure, but just to show that every procedure can be performed through distal approach. Every procedure that can be performed through proximal approach, because it's more or less the same.
Yeah, absolutely. This is a very interesting didactic case, because okay, you say that this is not a complex case, but we were in a setting of acute coronary syndrome with a left main procedure with 2 stent techniques, so it was not really so simple. But the concept is the problem is not the setting, the acute setting or stable setting. The problem is to become confident with the access. Then you can have the same advantages of the conventional radial access using the distal radial, adding a reduction in terms of vascular complication or in terms of risk of radial artery occlusion at the forearm. So this, I would like to underline that you mentioned it, that the mean time of our experience was during an acute setting was 125 seconds, so about 2 minutes from the anesthesia to the flush of the sheath. So very quick time to take the access. So this is a message that it's very important to become confident with the new access. Then in our daily routine or in our daily practice, we are used to puncture an artery with a needle and to advance a wire through the needle. So this is not so different from our standard, but you should become confident. You should know the anatomy. You should know different technique in order to puncture, and then you should follow your learning curve. And finally, when you achieve your experience, when you have your experience, you can start to perform a complex procedure such as CTO, or using this access also in case of acute setting. So I have a question. Sorry, I don't know if we have some previous experience regarding the cases when you need to repuncture the same distal radial. I don't know if in our experience we perform a repuncture in the same patient from the same distal radial. So we are sorry we have no experience in this situation, because we didn't perform a repuncture in the same patient from the same distal radial access. But I think you can change. This is another advantage of this distal radial access. Then you have to perform in the same hospitalization. You need to perform another procedure. You can change from distal to conventional, or from conventional to distal, from the left to the right. So this is a very versatile access, and it's I think that it's could be useful skills for all the interventional cardiologists in daily practice, in daily routine practice. So we are at the end of our presentation. I just want to show you last few slides regarding a completely different subset from acute to chronic, from acute coronary syndrome to chronic total occlusion. So just to show that this new distal transradial approach could be suitable also for a complex PCI such as CTO PCI, because there is a general agreement that it's better to use femoral access during CTO PCI, but during time the rate of transradial access in CTO PCI increased during time, and now we can assess that all the most of CTO PCI could be performed also using transradial access, bilateral transradial access. And we wanted to evaluate if this kind of access, the distal radial access, was suitable also for CTO PCI. So we know that we can use the radial access for CTO PCI, but we all know that sometimes during CTO PCI it's better to have 7 or bigger guide catheter in order to be able to perform some or different technique during the procedure. So this was our aim to evaluate the feasibility of distal radial access using a 7 French guiding catheter. And in this case, we decided to use the new sheet that at the time of this evaluation was the glide sheet slender from Terumo. We use systematically from CTO PCI the distal radial access. We collected 42 consecutive cases from 5 Italian centers, and we use the left distal radial access as a default access using a 7-in-6 glide sheet slender. And we would like to evaluate the feasibility and the safety of this approach in CTO. And this is the paper that we published on Eurointervention 2 years ago. And we collected 41, sorry, I said 42, but the patient were 41 consecutive patients. And we would like to evaluate a successful left distal radial access in terms of rate of crossover. The technical success that we achieve in this patient, evaluating in hospital MACE, major and minor bleedings and vascular access site related complication. And then for this reason, we use the ultrasound evaluation to study the left distal radial patency at discharge. This was due to the diameter of the 7-in-6 French, both from if we use the glide sheet slender of the range sheet introducer from Cordis, the diameter is very similar, about 2.79 or 2.8. So it's bigger than the distal radial artery diameter. So we would like to evaluate the patency. In terms of pain, we achieved the same, the pain that was referred for the patient. We achieved the same result of our experience in acute syndrome, and the pain that was experienced from the patient was mild or moderate. No pain, no severe pain was described for the patient. This was the technique that we discussed a lot, and this was the setting from distal radial access, from the left distal radial access, and from the femoral in this case. And the compression we discussed about, but we would like to show the final result. This is the procedure. It's not the topic of our presentation. We are at the end of the webinar. I don't want to bore you. So the procedure was successful, performing retrogradely with this very good final result. This was a procedure that was performed from Pietro Mazzarotto that you have seen in the picture in the previous slides. So the procedure time, fluoroscopic time, we collect all this data to evaluate if during this procedure use this kind of access, we observed some difference. There were no difference in terms of procedural length or in terms of contrast media that was used. The CTO mean, the JCTO score mean was quite high, so the procedure were all complex, but this was the result. The technical success was achieved in 90% of cases, and the procedural success that was described as successful in terms of left distal transradial access plus technical success plus no MACE was 78%. So it was quite high. The combination of technical success using the successful left distal transradial access. And the most important thing is that we didn't experience any distal radial occlusion at the discharge, and after 30 days of follow-up, just one patient that was a very small female patient experienced a case of distal radial occlusion. And then we have to note that we lost 8 patients at follow-up. So this just for underline that even in case of complex PCI such as CTO, or in case of the need to use a large bore guiding catheter, you can use the distal radial access using the low profile sheet such as the rain sheet, the rain sheet with ultra low profile. And that led us to use 7 French guiding catheter maintaining the lower outer diameter of the sheet. So the conclusion of this very interesting webinar is that we can use the distal radial access also in complex PCI, as I said just a few seconds ago. And then the advantages of this kind of access in CTO PCI is that if you use the left radial, distal radial access, you can achieve a strong support if you advance the guiding catheter for the right coronary artery, as in case of traditional transradial access. And I would like to say again, the enhanced comfort for the operator, especially during this long procedure, but even enhanced comfort for the patient, and the reduction in terms of radial occlusion at the forearm. And finally, the reduction in terms of time to achieve hemostasis. So I think that it was the last slide. Damiano, do you have some consideration, final consideration? We have finished the presentation in perfect time. We have 5 minutes. If we have some consideration.
So I think that the main key point of this presentation is that you have to feel comfortable with your vascular access of choice. But in fact, as Gabriele said, we are interventionalists, so to achieve a good vascular access is our job. We spent 12 hours a day searching for a good access for the patient and for a good access for the procedure. So it's not a big deal to find a new access. So we have to remember that interventional cardiology started with brachial surgical access, then moved to femoral access because it was less dangerous than surgical brachial access. Now we moved to radial, and we are moving to distal radial. But the main thing is that we have to find an access to work on our patient's heart, and we don't feel it like a problem. Here in Humanitas, Gabriele, Bernard, me, Paolo, Giulio, Giuseppe, Gennaro always think that one access is like another if you are comfortable achieving it. And right now for us, at least for Gabriele and me, distal radial access is becoming the first choice. Plus, we have also to say that right now our fellows and also our specializzandi use the distal radial access as a first choice, even for cardiac surgery and even for diagnostic procedure. And when they are scrubbed with us, while we are talking about cases or even with talking about any other issue, they are achieving always a good access through a distal through the distal radial. So it's not a big deal. You have to get used to it, but if our specializzandi can do it, I think that everyone can do it.
It depends on the skills. But no, okay, it's a joke. But I would like to conclude this this webinar. Say thank you to all the specializzandi that you mentioned, Carlo Andrea Privato, Fausto Roccasalva, that gave us a strong support in collecting data, in collecting image and video, and also to our fellow Jorge Sanchez from Spain, that we are waiting, and we hope he can come back with us as soon as possible. And special thanks to Gennaro Petriello. This is a colleague of us, for helping us, for collecting data, and for the enthusiasm that all of these young interventional cardiologists have in exploring new access or in learning new skills. And finally, I would like to thank again all the staff from Cordis for supporting this webinar, but also to support us in this project. It is that is a project in which we strongly believe, and we are working to improve our material and our experience in order to share with a large audience of international cardiologists. So thank you very much. Thank you, Damiano, for your support, and good evening to everybody, and see you soon. Thank you very much. Bye-bye.
Bye.